All right, so we'll get started. So we're just going to talk about the elbow. We're going to break this down on here, and I'll run through this. So a little bit about me. Michigan State grad. I got a BS in kinesiology with specialization in athletic training. I was an athletic trainer for Detroit Lions for a couple of years before I decided to come back to medical school. Wayne State University. I did physical medicine rehabilitation after osteopathic school at Michigan State. I was chief resident there. I was a Wayne State's team physician during my residency. Their team physician quit mid-season, and they knew that I was local and had my ATC licensure as well as my doctor's licensure, so they covered my event insurance. Pretty unique experience. I was head team physician for Seattle Storm 2016 to 2020. Recently started my own business, Elite Sports Performance Medicine. And then I'm board certified in PM&R, board certified in sports medicine, did my fellowship at Mayo Clinic, certified in MSK Ultrasound. I do a lot of teaching. Some of you probably know my name or know me. Feel free to stop by at AMSSM as well. I'll be doing some teaching there in the advanced ultrasound courses. This is from one of my favorite moments in life so far. This is when we won the championship 2018, last time we were all allowed in the locker room together. Anyway, pretty cool to go into a room, spray champagne, not only not have people not be upset about it, but also be happy. So again, in sports medicine, oftentimes you ride on the coattails of these great athletes, stuff I could never do myself. So. All right, so kind of here's going to be our breakdown. So we're going to go over the anatomy of the lateral elbow and medial elbow. And then we're going to go into kind of like a couple case presentations, and then go into talk a little bit about tendinopathy, how it's traditionally treated, and then with ultrasonic sonometry, we're going to break this down step by step here and go over some of the evidence. So your lateral elbow scanning protocol, this is from AIUM protocols. These are the reasons we want to look at the lateral epicondyle, the common extensor tendon and muscles, the lateral collateral ligament complex, the joint, kind of looking dynamically to see if there's anything going on there. Radial nerve, its course through the supinator, proximal attachment brachioradialis, and then a little bit more advanced. I'm going to cover these as well because these are structures in the area that we should kind of take note of if we're going to be doing procedures around this area. So again, superficial radial nerve, looking at the lateral antebrachiocutaneous nerve and the posterior antebrachiocutaneous nerve, and I'll show you how to find those. So my scanning position for this, usually I do it seated. This way I can point things out to the patient with a couple pillows under the knee. This is comfortable for the patient. It's comfortable for me. You'll learn when you start doing more and more ultrasound to be more ambidextrous, and so you can scan with either hand. So taking a look first, we're looking at the common extensor tendinous complex. So this is really 4 tendons coming together in one. So it's really important to know that. And so just kind of looking, this is to the left of the screen. This is left of the screen is proximal. This is distal, and this is a long axis view. Just go over some of the abbreviations. This is a radiocollateral ligament. At the bottom, 54% of this slope is radiocollateral ligament. It blends in with the annular ligament, which you'll see here. And then here's radial head, lateral epicondyle. Here's, I say common extensor tendon, but this actually looks like the ERCB that I had on here. And so we're going to scan across all 4 tendons by scanning back and forth. And I'll break this down individually and how you can individually assess which tendon it is. And our cadaver that we're going to use today actually has some pathology in his ERCL, which we'll see as well. And so now we start with a short axis view. Here's your tendons here. So you're going to see the ECRB is going to come up from underneath and end up superficial. Your EDC is going to be in the center, and your ECU is going to be lateral, and then anterior or posterior, and then anterior is going to be ECRL. Now the ECRL, the thing to note about it, the muscle belly goes right up to the tendon. So it's the most proximal muscle belly that you're going to see. And then this is your brachioradialis here. So you're going to see that in live scan here. And you're going to see those tendons. You're going to let this play a couple times. We notice that distal muscle belly, the ECRL, that kind of gives it away. And it actually attaches at the supracondylar ridge. So you can see it's right up at the top. And so, and then we've got our, again, the bottom 42%, or 54% is a radiocollateral ligament here. So we can see all 4 of those tendons coming together for a tendinous complex. So now let's break them down individually. So at the top right here, we're going to see the ECU tendon. I'm going to scan up on it, and we're going to turn, and here it is here, and it's going to form the ECU tendon, which one of the thinner tendons. When I see pathology in here, this is less likely to respond to most treatments to it. So good to note where that's at. And now we're going to see the EDC. It's going to come up in the center here. There we go. I'm going to turn on it. And so here's our EDC with the ski slope over the joint. Okay, now we're going to look at the ECRB. You're going to see it loop up from underneath here and end up superficial. Then we're going to turn on that, and you can see your ERCB. And your ECRL, we're going to follow this muscle belly all the way up. And then we're going to turn on that. So obviously it takes time and practice to learn how to do this. I'm doing it very quickly on here. You don't have to do it that quickly, but I did it just so it fit in the sine loop that I assigned it. So, okay, so that's each of the tendons individually. And so common extensor tendinopathy, what are some of the findings of it? Hyperechoic heterogeneity. We should never see neovessels in the center of a tendon. So this is part of that ineffective attempt at trying to heal it. The neovessels are actually part of the problem. It's a sausage on a grill phenomenon, which I'll explain in a second. Partial thickness tearing. This guy's got some partial tears in the radiocollateral ligament and into the ECRB, which is very common. Most commonly affected ECRB in the literature, if you look at that. But be sure to check for dynamic instability. Always check the annular ligament, check for PIN, and check for the lateral ulnar collateral ligament, because these change your kind of treatment ideas. Is like, why is it happening? If they have elbow instability, that's a whole different problem. Certainly, if you see this, a full thickness rupture of the radiocollateral ligament, annular ligament, and most of the ERCB, you don't want to do, this obviously needed surgery, but this is following a palpation-guided steroid injection. So here's some common extensor tendinopathy with partial tear. So you can see the tear in the sentiment. In my opinion, I've treated probably 40,000 tendons at this point, that most tendinopathy has a partial thickness tear, either the micro tears in it. So now you've got one of two options. One, that tear is less than 20% and people can get used to it. If the tear I find involves more than 20% of the tendon proper, those are the people that continue to have pain. So this looks like a small tear, but when we inject this with lidocaine, it opens the tear up, and it actually ends up being a significant amount of this gentleman's tendon. This was treated with a TX2. Here we are at 6 weeks follow-up. So you can see still doesn't look completely normal. This is more normal looking tendon here. The tear is starting to fill in. And then here we are at 12 weeks. The tear is filled in. He maybe has a little bit still healing here, but more importantly, he was pain-free by 7 weeks. So even getting it under that 20%, stimulating healing response enough to get it under that 20% will help these patients feel better. Let's take a look. This is the old way of doing calcific. I don't use this as much anymore, but this is me barbitaging this out. This is a calcific tendinopathy of the common extensor tendon. Now, for people that do a lot of tendon treatments like myself, yeah, I've seen this in any tendon in the body, more common in females, more common perimenopausal females will tend to do this a little bit more commonly, 11 times more common, in fact. And so now this is what that looks like when we do it the old-fashioned way, 20 to 30 minutes, not to mention the fatigue on your hands after you do syringe and syringe and syringe of this, because eventually this gets so cloudy that you can't see it anymore. So this patient did well, but at the same time, this took, it takes 20, 30 minutes of my time. Or if you accidentally poke through the back wall of it, you can do a 2 syringe system. This is from a publication of mine in 2016, and you can blast it out. Again, time consuming. The ultrasonic tenotomy is much faster. Here's a patient that was treated with ultrasonic tenotomy. Unfortunately, I couldn't find the original images of the actual device in there. But you can see this is tons of neovessel formation, a big hunk of calcium sitting right in the center of this. Again, it took me 2 minutes and 34 seconds. So a lot different than, spending 20 minutes doing this. If I can spend 2 minutes doing it. And in my opinion, this gets more of it out of there with the ultrasonic tenotomy, and which, potentially a better outcome, although it's never been studied, but certainly better on my forearms. So let's talk about the ligaments here. Lateral collateral ligament complex. What are we talking about? We're talking about the radiocollateral ligament, the annular ligament, and the lateral ulnar collateral ligament. And I'll show you how to look at all these under ultrasound. This is a great cross-sectional study by Textera in 2011. So let's look dynamically at the annular ligament. So what I'm doing here, you can see I'm anterior to posterior with my transducer position, and over the ulna, here's my anconeus muscle, and you see the ligament. I can make it taut by pronating the forearm, and so I'm checking to see if this is torn or not. If this is torn, usually I got to look and see if the buckle's torn. I've never seen the lateral ulnar collateral ligament not torn when this is torn, although I'm sure it happens in the literature. But if this is kind of my soft sign of like, ooh, I got a bigger problem here than I think, right? And so here's a case from a couple weeks ago. This is a complete rupture of the annular ligament. So this patient has a bigger problem than, she also had a tear in her common extensor tendon, but if I treat that, but I don't have, this is something that obviously had to send to a surgeon. But if I didn't deal with this instability, she's going to get rotatory instability of her elbow. Her buckle was also torn. And so, oops, this is a great study about the radiocollateral ligament done by Jacobson et al. I think 2014, 2015, somewhere around there. The bottom, so what they did is took cadavers, dunk them underwater and ultrasounded them, and were able to dissect out just the common extensor tendinous complex, showing that the bottom, on average, 54% on these cadavers was radiocollateral ligament. So if you're trying to treat the tendon, treat the tendon. If you're trying to treat the ligament, treat the ligament. And so you want to make sure you stay above that 54% of the slope. I think that's probably the key point here. So now this, right, bottom 54%, this is a radiocollateral ligament tear. This is a bodybuilder. He had 2 or 3 years of pain. And you can see this is more torn towards the posterior aspect of the elbow. This is a short axis view of the same tear. I ended up treating this with leukocyte-rich, platelet-rich plasma. You can see this filled in here, and it's also filled in here by 3 months. So again, lateral ulnocollateral ligament tears, it's a #1 cause of chronic rotatory instability of the elbow. What's that going to lead to? This is that patient that comes in and has horrible elbow arthritis after a fall years earlier. So something to watch out for, that patient comes in with elbow pain. So again, make sure we're looking for this, and I'll show you how to find this on ultrasound. So again, look at the angle here. So we're going to start short axis over the or long axis over the radiocollateral ligament, and then and radial head, and then we're going to rotate until we see the ulna come into view. So you're going to see that on both these videos here. So this is going to rotate until I see the ulna come into view, and then I'm going to look for that ligament. You can see it here. Okay. So again, watch on here. I'm turning, in this case, clockwise, and I'm getting till I see this on the screen. So I see that ulna come into view, and I'll show it one more time here. In line with the radius is going to disappear. Radial head stays in view, and then I'm going to see the ulna, and there's my radial ulnar collateral ligament. So again, looking for tears in that, pretty important. Okay, so let's talk about the nerves. So radial nerve, so it's going to come around the spiral groove and then head down to the front of the arm, and usually immediately splits. We'll talk about that branch right there in a second, but let's follow the radial nerve all the way down until we get to the antebrachial fossa, where it's going to split again into posterior neurosseous nerve and the superficial radial. And so again, pretty normal for it to change a little bit of size here from round to oval to round. That's pretty normal. You'll see that size change here as we wash this down. Again, about 10 to 20% of humerus fractures, it's called a Holstein-Lewis fracture, will entrap this nerve at this intermuscular septum underneath the long head of the triceps. So Saturday night palsy, I unfortunately had one of our neurosurgery fellows here fell asleep on a plane and got one of these, and he never got his radial nerve back, but pretty interesting. Tumors, etc. There's a lot of other reasons for this to get caught. So now posterior neurosseous nerve, we're going to see it split off here. In this case, this patient has a leash of Henry, so you'll see it go, the recurrent radial artery go back over the top. But this, to me, I always know when my fellows have made it because they can scan this one all the way through. It does a 180-degree turn around the elbow. So you're going to see, here's a scanning of this. And there it goes into the elbow. And we're going to follow it all the way around the supinator here. Okay, out the back. And so again, this is an example of a leash of Henry. You're going to see the artery going over the top of the nerve. Okay. That normally gets a little bit big as it goes into the arcade of Frosch too. But I think the reason that happens is most people have some subclinical PIN entrapment, and we'll see that here. This is, you're going to see, looking at this dynamically, let's watch what happens to the nerve here. You're going to see this little muscle herniation here. Whoop, see how it's raising the nerve up? Now, what's that look like along axis? Let's take a look down here. See how it's tethering the nerve? This is my elbow, by the way. So I get PIN symptoms. So that's what you're going to see there. Okay, great. Let's head on to the next slide. So maybe be sure to check dynamically, kind of the key for that. There it goes. Okay. And so now we're talking about a leash of Henry. You can see the recurrent radial artery going over the top of the PIN. That's your leash of Henry. Here's an example of this in long axis. You can see clearly squishing down. You can see how the nerve has to go underneath that area. So just another possible realm of entrapment there. Here's an example of the most evident one I've ever seen. Did you see the nurse that like winked at us? Whoop. Anyway, so this is a true leash of Henry issue. This person was a guitar player, had to have this clipped, and they actually just ended up, I think, clipping the artery, which fixes guitar player's issue. You'll see how big, that's a big fascicle of a nerve. And then this is that same nerve in long axis. Here's the recurrent radial artery, and there's the nerve. Looks like it's been a garden hose that's been stepped on, and so nerves tend to get fat when they get pissed off. So that's a technical term for it too. And so I've seen this nerve have all sorts of issues. The reason why you look at it, here's a ganglion from the joint. So that's causing the nerve to get displaced and causing issues with the PIN. Obviously, you check your Doppler when you see this. You'll see this is me. There's the nerve and there's the cyst. So nerve, cyst. So you can see how close they are together. Here's having some PIN symptoms from that. So here's one that got entrapped distally. So when we watch this thing exit out the back, you're going to see this come on here. See this? Whoop. This is why it's important to follow it all the way through. So this is he's getting distal entrapment. So might miss that if you don't follow it all the way through there. Here's a PIN that got cut during surgery. This is one that you're going to see, whoop, there's our incision. The nerve just kind of disappears after that. Show that to you in short axis or one more time. Whoop, nerve just kind of disappears. Here's my long axis view of that showing the nerve is sitting, a centimeter apart from itself. So, and then this is a fun one from last month. This is a this ended up being a neuroangiofibroma. At the time, I wasn't sure what it was. I knew it didn't look good. Lots of vascular through this tumor. This is a little muscular branch off of the radial nerve that's going to the brachioradialis. So C7, mostly brachioradialis. And so this little branch here turned into that. So, and you can see it's actually in the nerve. This is the nerve running this way. And then, anyway, he was fairly symptomatic from that, but you can see how close it is to the PIN. Whoop, just gets squashed out of the way. So, all right. So anyway, a little bit lateral antebrachiocutaneous nerve. It's going to come out from underneath the biceps and brachioradialis and head laterally here. So just note it's there. You obviously don't want to hit any of these nerves when you're doing procedures around here. Now, this is the nerve that nobody thinks about. That was really a great paper here by Smith, J. Smith and Maeda et al. Out of Mayo, dissecting this posterior. So this comes off the posterior cord and is the lateral epiphyseal branch of this, or lateral epicondyle branch. And so you really want to watch out for this lateral epicondylar branch of this posterior cutaneous nerve of the forearm. And so again, here it is here in their dissection, which is great. And it goes right over the top of the lateral epicondyle. So it's superficial, sitting right on top of it. So just be careful if you're, tenexing or doing procedures up there, that it sits right there. If you got that patient that has real nervy pain there, think about the neck. As someone who had a C7 or DIC and had to have surgery on it, I had tons of elbow pain right in this area. So here's this initial split up high. So you're gonna see that up high split. Here it is here. This is immediately splits off of the radial nerve, right distal to the spiral groove, and then splits into anterior and posterior division. So you're gonna see it'll split again, anterior, posterior division. Okay, so this is kind of how you can trace it down. And it's the posterior division we're gonna pay attention to. So as we get down to the wrist or to the elbow here, you're gonna see it split again into this epiphyseal or epicondylar branch, and then the branch nerve to the anconeus. And so we're going to see it split here. Whoop, and we're going to follow that little branch down. You see it went right over the epicondyle. So just be aware that's there. Probably good to note that this is where you're going to get into trouble. Okay, switch focus to medial elbow, and then we'll kind of get into tendinopathy and how to treat it. So medial elbow scanning protocol, we're going to look at the common flexor pronator tendon, which is, again, a combination of 4 tendons, and I'll show that to you again here in a second. The ulnar collateral ligament, particularly the anterior band, and then you can stress this as indicated. The ulnar nerve, right? This is the guy that's going to get you into trouble. And it does have a little branch that goes over the epicondyle as well. Dynamic flexion extension, looking for a snapping ulnar nerve. You want to know if it's going to be in your way while you're doing a procedure. Look for a snap it, a triceps, look for an anconeus epitrochlearis, an accessory anconeus. And then I always look at the biceps tendon when I'm medially. I look at it laterally as well as part of my lateral protocol. But I threw it in here because it's easy. I'm going to take a little sip of water. All right, scanning position, lateral recumbent. I lay them on their side. It's so much easier. Then they can bring their arm out, kind of similar to what you're seeing on here. So this, pillow between the knees, make them comfortable. And that way, if I need to stress it, I can very easily put a weight on it and stress it and standardize it. In our study from 2015, we used a 10-pound weight just to try to standardize this a little bit. 10 pounds is more than enough to gap this joint, and it's not super uncomfortable for the patient. I guess you can use your arm and get a general idea if you wanted, but just trying to make it kind of standardize it. You can do it manually as well. So first thing we're going to look at, let's take a look at the tendons here. Here's what we're going to do. I'm going to start over this UCL here, which is here, and then I'm going to rotate up in this case, clockwise, and slide a little bit anterior, we're going to see these tendons come into view. And then I'll show you this in short axis. So now we've got my flexor tendons, and then on the top here, the more superficial tendon, this is probably my FCR, and then the pronator teres will be over on the top of it here, what you're seeing on this image. Sometimes they look like this, where you see them coming together. So just note, it's a combination of tendons, and I'll show this to you in short axis, and this will make more sense. So now I like looking at this in short axis, because you're going to find, you're going to get a lot of better idea of which tendons are actually affected. And then you can be very specific with your manual exam once you know which tendon is affected. So, so the most lateral tendon to attach here is going to be the ulnar head of our FCU. And then we're going to get the flexor tendons, FDS and FDP. The FCR actually blends in right at the top up here. And you'll see that as we come down here. And then our ulnar nerve is going to be sitting posteriorly. So here's the ulnar nerve at the true cubital tunnel. That's where this video is going to start. And we're going to see it come up here. And note, there goes my ulnar head of the FCU, right? We'll follow that first. Oop. Now we're going to follow our EDC and I'm sorry, flexor digitorum superficialis and profundus. They're going to come up here, right? Here's our FCR coming up here. It's going to blend in at the top. See that most superficial part of it. And then we're going to have our pronator teres come in at the bottom, or at the most anterior. Okay, so this is what common flexor tendinopathy looks like. This is a partial tear in the pronator teres, but it also goes into the common flexor tendon. You can see that here, how it kind of extends up and goes. This is a very ugly looking short axis view of this. It's not a healthy looking tendon, but again, note this nerve, sometimes if it's subluxing and you have the wrong angle, it can be sitting right over the top of your ulnar nerve. So just be aware where that's at. It's obviously the most at-risk structure here. Looking at the optimal, so by the way, this is a study from 2015. We looked at the optimal angle to look at the UCL, and it was 70 degrees. So not 30 like you would see in a lot of the textbooks. 30 degrees, honestly, it's not even taught, which it makes a lot of sense when you look at the cadaveric studies where they cut this. It was most taught at 70 degrees. So not 30. I'm not quite sure where that number 30 came from. That would tell us in medical school, but it's not accurate. Again, here we can stress this. Here's a distal UCL tear. These distal tears do worse with just about anything. This one went on to surgery, but you can see that's a capsular T sign. We're seeing some of the fluid come out of the joint here. This is a Major League Baseball pitcher that one went on to surgery. And then again, looking at the biceps tendon here, this is called the pronator window. You're going to start on the epicondyle, slide forward, and then you're going to keep going forward until you see the ulnar artery. And so, and once we see the artery, we're going to see through transmission to the biceps tendon. Okay, so again, sliding forward, that's brachialis. Now we're going to see the ulnar artery, not ulnar artery, I'm sorry, brachial artery, and then you're going to see the tendon come into view. Okay, so we can look at that and scrutinize that from there too. This is what biceps tendinopathy looks like. So this is a tear in the short head, actually. So this is what a normal one looks like. This is what the other side looks like. If you have a ultrasound machine that can have the suppression of the artery on top and just get the window here, you can see some hyperemia in there. It's usually there. Sometimes it's hard to see depending on your ultrasound machine. Here's a partial tear of one here. This is a short head torn. This one was treated with leukocyte-rich PRP. There's 12 weeks after treatment. This patient came back in for the other side at 1 year. So I thought, I'll take a look. So it doesn't look completely normal, but this person was pain-free. So anyway, kind of a cool case to see it again that far out. Now the ulnar artery, or ulnar nerve rather. We're going to follow this down here. It's gonna loop around, starting kind of mid-humerus there, loop around retrocondylar groove, come back out. You're going to see the two heads of the FCU, follow it down through the cubital tunnel. So I'll let that play one more time. Again, notice that little epiphyseal branch. I want to point this out here, this epicondylar branch. So keep your eye right on this corner of it. You're going to see it pop off. See it? So it is sitting there right behind it. So just be aware it can have variable position of it, so you know where it's at. All right, still hanging in there? Now let's talk about ultrasonic tenotomy. So I know that was a lot, but I want you guys to understand that this is more complex than just sticking a needle in somebody. And if you want good results, you have to be able to scan really well and understand the anatomy. And then hopefully you can go back and look at this and understand, you know, where maybe you could be very specific what tendons affected, and it probably affects your rehab. That way you can be specific with the rehab as well. So again, tendinopathy affects a large amount of athletes. As I told you before, I'm convinced that these all have micro tears in them after years of treating them. These micro tears, if they're less than 20% of the tendon, people can live with it. I lived with mine for 9 years until I tore it enough that I had to do something about it. Anyway, it's about 30% of consultants for MSK pain in general practice setting are for tendinopathy, tendonitis, partial tears. Again, we know it's not an inflammatory response. We biopsy these tendons, no inflammatory cells. It's a chronic degradation of the tendon. I kind of think of it as tendon failure. So you're going to see this breakdown of the type 1 collagen replacement with type 3 collagen, which is less able to withstand tensile load, or replacing it with calcium hydroxyapatite, which also does not respond to tensile load. So this is a big problem in our society, and it causes a lot of issues. Traditionally, corticosteroids are offered as a next stop. I'm going to tell you why I don't do this ever. I guess maybe if you're 90 years old and you want to feel better, come get your steroids. I rarely inject steroids anymore. There's other products out there, bone marrow, this is beyond the scope of this talk, PRP, A2M, placental derived products. I don't use those either, but anyway, needle tenotomy with orthobiologics, et cetera. And so now we got kind of ways that are kind of minimally invasive that are kind of a combined approach to this that I always take. If there's neovessels, I tend to do a tendon scraping. If there's tissue that's bad in there, I'll tend to do an ultrasonic tenotomy and debride it. And then I'll also sometimes combine it with high volume injection, and then consider bringing in orthobiologics. Again, argument against steroids and why this product, ultrasonic tenotomy, is such an important tool for us than injecting steroids into everyone. We've known since 1977, yes, that's over 45 years ago now, that it causes tendons to rupture. We've known since the 80s it's toxic to cartilage. What are we doing? Are we trying to send our patients into joint replacements and rupture their tendons? I think it's insanity to not ignore this data. Great study out of HSS from 2019, Kompel et al. Just read it. It's really good. And that's on osteoarthritis, and the fact that even after one injection, you go, one's probably okay. Maybe it's not in some people, and it pushes them towards ruining their joint. Anyway, again, this is probably not what's best for our patients. So I like to think of tendinopathy as a sausage on a grill phenomenon. So you're gonna laugh at me about this analogy, but you'll never think of it the same way. So if we have a tendon that looks like this is a yucky looking Achilles tendon, one of the worst I've seen in a while. Actually, it's pretty bad. Anyway, there's a partial tear up here. There's probably another one up here. But these got these extensive neovessels. Now, if you measure the thickness of a patient with neovessels, have them go run up and down the stairs for 5 minutes, and then remeasure that thickness, it gets thicker. So what's really happening here? It's an enclosed compartment. What happens in compartment syndrome? The intratendinous pressure goes up. And we've actually stuck stick catheters in people and determined that this phenomenon actually happens. So these neovessels allow blood to get into the tendon, but then it can't get out. And then what happens if intratendinous pressure goes up? You get cell death, you get more tendons rupture, you create more micro damage. Then you repeat this process, your body forms more neovessels, and you get stuck in this cycle. And so the part of this is like, how do I stop the cycle, right? So if I had a sausage on a grill that's about to explode, I've got a couple options. I can turn off the gas. That's called a tendon scraping. Lots of data, over 30 years of data from Albertson Haken on this. Works very effectively. You can do a needle tenotomy. People have been doing that for years, poking holes in it. Somewhat effective on some tendons. I don't think that would help this person out very much. Peritoneum on slit. So if they have a tendon sheath, you can slit down it. That's been done in multiple tendons to provide relief. Somewhat effective. Mufali et al. Published all that on that. And then, or I can do an ultrasonic tenotomy. If I could remove some of the meat out of this sausage, it wouldn't explode. And that's where 10x comes into play. So turning off the gas. So this is from a publication that should be out this year on minimally invasive or invasive procedures for the Achilles tendon. Anyway, this is a dual blade meniscotome designed for the knee. Originally, when Albertson Haken would do this, he would cut a big slit down the side of the Achilles, take a scalpel, cut off the neovessels. Did it for years in professional soccer players on the Achilles and patellar tendons. Great results, actually. So we thought, gosh, could we make this less invasive? Obviously, we don't want to hit the nerve here, the tibial nerve or the sural nerve running down the other side. So yeah, we can do this on our ultrasound. We can separate this out. It looks like this when you're done. Get the Kager's fat pad out of it. Fairly effective in season. Oftentimes, I get people back within a couple weeks after doing this to full sport. Poke some holes in it, needle tenotomy. Again, there's another micro tear there. it can be effective, though I don't find this as effective anymore. Or we can remove some of the meat. Here's our Tenex procedure. Again, removing or ultrasonic tenotomy, removing the diseased tissue out of here, right? And obviously it's got you can turn it on high, try to remove this enthesophyte if you thought that's part of the problem, etc. So basically debriding the area. So what is ultrasonic fasciotomy, tenotomy? It's a way to debride the tissue without damaging or doing minimal damage to normal tissue, as long as you don't let it overheat on you. It's the same technology, been around for years to remove the cataracts from an eye, something called phacoemulsification. So everything on Earth has a refractory rate to sound. If I scream at the right pitch, glass is going to break. And if you can figure out what the refractory rate to sound that a certain tissue is, you can debride it and remove it through this tube within a tube system, right? Again, mostly type 3 collagen, which can't withstand with tensile loads as much, has a different refractory rate to sound than normal tissue. And so we can actually remove this and remove the meat from the sausage, right? And that analogy I gave you. 34 peer-reviewed publications, 2 recent ones. I'll cover those in a minute. 90% of patients with up to 36-month follow-up were satisfied with the procedure on the elbow. This is just some other data from some other tendons. We'll concentrate on the elbow for today. Again, this is a rabbit model where induced tendinopathy in rabbits, had them run around, treated them with the device, had them run around, euthanized them, cut up the tendons, looked at the tendons, able to specifically target type 3 collagen with the right settings, and leave type 1 collagen alone. And bonus, the areas that were debrided appropriately filled back in with tenocytes, which is what we want to see. And so this is a schematic of it. Most of you guys have seen this before. Again, we after numbing it, make a small nick in the skin. We're going to guide the device down through that small nick in the skin, and then insert the device into the diseased areas of the tendon, turn it on. It's going to show it vibrating here. You can't really see it with your naked eye. And then it's going to have a flush fluid in and suck it back out through a tube within a tube system. Okay. And then this is from a publication that should be out any day now, that we just, and I'll show you the data from this. This is just our setup for lateral elbow. I have them lay on supine on their back. Usually I put a pillow or an arm board under here, sterile towels, and then clean the area really well. And then I'm going to go distal to proximal for this particular tendon, which I find is very effective because then I can see where that lateral branch of the nerve is, the epiphyseal branch of the posterior femoral or posterior cutaneous nerve of the forearm that runs right over here. And so again, that's our setup for it. Here's our setup for the medial elbow. And so I lateral recumbent, same position I do for, this is a little bit more accurate than this. I just threw this picture on there for show you guys a lateral recumbent position. Anyway, I'm going to come distal to proximal. I'm going to keep the ulnar nerve in view the whole time, running back here, and work through the tendon that way. This is evidence from Coe et al. They got a couple publications out on this. Again, our data is a little bit different, usually by 2 weeks, they were really no better, but I'll show you our data, and we had a higher volume of patients, but again, improvement across all measures over time. This is a study I published in 2018, looking at 2 patients that had failed an open tenotomy with tenodesis, and still had a ton of neovessels in here, as you can see, and still had issues. The surgeon sent me and said, "Hey, can you tenotomize these with the Tenex device?" And I said, "I'm not so sure, but I'll stay away from the suture anchor." So this is the suture anchor here on this patient anyway. And so I kind of try to avoid the suture anchor, cleaned out the area. These patients actually did really well. You can see here's a suture anchor on this one, and got better. Here's the 38-year-old male. This is a 90% tear of the tendon here. Also radiocollateral ligaments involved as well. This is, so I did a combination. I get a lot of talk, why not combine this with, platelets? Why not? And so we're collecting data on this right now to see if there's a difference. But I think, and just anecdotally, the concept makes sense to me. Dig a hole and then put it in the best environment to heal, right? So debride it back to healthy margins. Fill it up with something that's going to promote a healing response. This is 6 weeks after treatment. This is 12 weeks after treatment. This patient was pain-free by 8 weeks. And by the way, this is my elbow. and I did the treatment myself. I had my fellow hold the transducer. So I put my money where my mouth is here. I thought for sure I was going to need surgery after my dog tore this, then dealt with this for 9 years, 9 months of more severe pain. And eventually got to the point where I could barely hold anything. But mine took about 8 weeks to get the pain free. By 6 weeks, I was about 50% better from pain. And I kept close track of my results, maybe because I still had this radiocollateral ligament that was healing here. I don't know. But then 8 weeks, I had a pain-free day, and I thought, oh, it's probably just having a good day. And then it took me about 4 months to get the strength back where I felt like it was equal to the other side. But here's our data. This is 80 patients, but 68 that we were able to complete the study. Our DASH scores noticed by 2 weeks about the same, but by 50% improvement by 6 weeks. And then by 12 weeks, still not back to normal, but from 12 weeks to a year, people continue to improve. And I thought that was the most notable thing on here, is that if they're not better at 12 weeks, don't freak out. Some people were outside of our bell curve and got better by a year. Notice too, a lot of people still had the hypervascularity even at 12 weeks, and then that went down considerably over the year. The hypoechoic heterogeneity went away by 6 weeks in most people, but then also kept improved. About 94% of our patients were satisfied with it. But again, this is what's different than from our data from the other ones, is by 2 weeks, people reported maybe a 1 point, 1 to 2 point improvement in pain, but overall, the biggest jumps were from 2 to 4, 6, and 6 to 12, and then the slow trickle out to a year. Here's just some of our patients from that study. This is initial large partial thickness tear with this one had a bunch of neovessels in it, and then not pictured here, obviously. Here we are at 6 weeks, so you can see this tear is kind of closing off and healing from the outside in. Here we are at 3 months. And here's a patient that wasn't better by 3 months and still had this area of healing that hadn't really changed all that much. And then that's the same patient at a year. So giving it some time to go, kind of the key. Now, this is really important here, is our average energy time, 152.2 seconds. So I'm not in there for like 5 minutes, right? 2.5 minutes, right? So you're not spending a ton of time to do this, just kind of zapping it, get the bad type 3 collagen out of there, work through the area like a grid, and then get out. And then, if you're going to add something to it, add it then. Little word of advice: if you're going to add orthobiologics to this, come in from a different angle. 1, 2, close your incision first, glue it shut, put your stereo on, close that incision first, and then come from a different angle to put your orthobiologic in. Otherwise, it's like Roger Rabbit after he's been shot, and you just, comes right back out. And so we had no recurrences, no open surgical conversions. About 8% of our patients didn't get any better or any worse with this. Anyway, and you can see this is just a bar graph representation of the same data. So talk a little bit about post-procedure protocols. A recent study came out showing that patients did better in that study when they had PT versus not having PT. I go back and forth on this. I think in general, if you have them buy a flex bar and start eccentrics right around 6 weeks, I don't start anything type of eccentric exercise till 6 weeks. And I obviously modify this for everyone, but this is just kind of my general one protocol for it. I have them leave the steri strips on for 7 days. I give them enough dressings to kind of get them through that time frame. They can pull them off at home if they're comfortable, or come back in the office or whatever. I used to do in-office visits at 2 weeks. Now I just do virtuals, show me the incision, see how you're doing, and then I see them back at the office at 6 weeks to rescan it. Again, these are just kind of general guidelines. No more than 2 pounds for the first 2 weeks, and then once we get up to week 6. We can start week 5, 6. We can add like 4 or 5 pounds, weight, and then I can give this to any therapist, and they can start integrating multiple joints, or can integrate this into any program. So, and then from 6 to 12 weeks, the reason why it's so vague is mine took 8 weeks to turn the corner. I've seen people as early as 4 weeks tell me they're pain free. I've seen people as late as 6 months tell me they're pain free. So everyone's a little different. So I'm obviously modify this per individual. Not everyone goes to formalized rehab. I usually have people buy a flex bar again. I demonstrate how to use it at the 6 week visit. I tell them to buy it at the 2 week and then bring it in with their 6 week. I don't add eccentrics till after 6 week follow up in the office, where I've had a repeat ultrasound and demonstrated healing. Again, so kind of a take home points about this. Ultrasonic tenotomy is safe. It's thousands and thousands and thousands and thousands of patients. I can't remember what the number is, 90,000 last time I looked. minimal complications to report to date. Peer-reviewed literature has reported good to excellent outcomes. Multiple different tendons treated with ultrasonic tenotomy. Patients may benefit. Maybe PT may be beneficial and superior to no PT for the elbow. This study just published. I don't know. I kind of go back and forth on it. I think it's based off the individual. So always know the at-risk anatomy is more complex than you think, as you can see from this presentation. And then working on ultrasound scanning skills will result in better patient selection and better care. So just kind of the key, you can train a monkey to stick this needle into anyone, but you can't train people to scan without experience. So on that note, I'll just kind of open this up if anyone on the floor here has any questions for me and wants to throw them in. I don't know if there's like a chat box. So you can always email me too. That's fine as well. If anyone have any questions?
Can you hear Adam? Can you hear Adam?
Yep.
Yeah, this is Gary Chimes.
Gary, how you doing? Had a long time no see, buddy.
Yeah, likewise. For the choice of patient selection, if you had like, I guess, between calcification versus tendinopathic tissue without a tear or tears, and I guess in your case, you're saying that you think most of the tendinopathic have tears.
You know, Gary, like when you inject these, you're injecting when you're like, oh shit, there's a tear in there, right?
Right.
Pardon my language, but and you're like, oh, okay, there's a micro tear here. No wonder this is sticking around, So I think probably majority, I think all of them have tears, to be honest with you.
Yeah. So let's say those criterion. Are there any of those that you think are inappropriate for Tenex? Like, let's say you don't have calcification, but you just have tendinopathic / torn tissue.
I'm less likely to debride it if it's not an overly thickened tendon, right?
Yeah.
It depends on how long it is, right? Sometimes I've seen calcific tendinopathy. I know you have too, just set in overnight. I mean, I had a hairdresser the other day that had it in her elbow that literally had like 3 days of pain and had a nugget the size of a golf ball. So that one, just try to flush it out in the office as best I can. And if it doesn't get rid of it, then I'll go for like a Tenex procedure. If it's a real hard nugget though, and these have the different appearance of them, I'm more likely, or if it's like an extensive area of the tendon, rather than just 20 syringes of pumping for an hour on it, I'd rather just Tenex it and just suck it out and go with it if it's calcium. Now if it's a tendon that's got like maybe a couple, I'm like, man, I can't really, the tears aren't obvious on ultrasound, and I'm like, I'm sure they're there, I'm more likely to go for an orthobiologic. If it's a thickened tendon though, that tendon's thicker, tons of Neal vessels, I'm going to suck all that crap out of there. I'm more likely to go for a Tenex. But I certainly don't think you're burning any bridges. I've been caught in that dilemma too, where I'm like, kind of on the fence, less invasive to inject something versus, cutting a hole in there and debriding it. And I have had some that I've done platelets on, or, whatever, orthobiologic, and they didn't get better. And then I do Tenex on, and they do great. Or I've had ones I did Tenex on, didn't quite get there, and I followed up with an orthobiologic at 6 to 3 months, or 3 to 6 months, and they're like, usually if by 3 months they're like, man, I'm still having a lot of pain, I'm like, okay, tendon doesn't look where I want it to be on ultrasound. I say, come back in a month, let's see where you're at. And if sometimes they start turning the corner in that extra month, and sometimes the hardest thing as a physician is let's just pump our brakes. Our data had a whole bunch of people that were outside the bell curve, so sometimes just a little bit of grain of patience on it, and with the patient, and say, look, you're just outside the bell curve. We're going to get you there. We may have to do something else, but let's just see how this goes. But yeah, hopefully that answers your question. Yeah.
Yeah. Thank you.
Yeah. Any other questions? All right, great. Well, I'm going to switch over then. And if anything comes up in the interim here, I'm going to switch over to the other room here, and we're going to go get set up for show a cadaveric example on here. All right, just be a second. All right, can everyone hear me on there? All right, great. Hope everyone can hear me. Okay. So again, I'm going to throw an arrow up on here. So we're looking at this lateral elbow first. I'm going to scan with my right hand so you guys can see a little bit more of what's going on here, and then I'll do the procedure with my left hand here. Normally I do it with my right hand, but that's okay. Part of being ambidextrous here. So we're going to see our tendons complexes come together here. So on the outside here, I've got my ECU tendon, and so we'll follow that one up first. And that one's going to insert down here. And then I've got anterior to the left of the screen. And you're gonna see he's got a little pathology here. This, I think this is a nail, looks like a nail arm. A little pathology in the radiocollar ligament that goes up into the ECRL. So a little bit of stuff in the ECRL coming up here. And that's that most distal muscle belly that we're gonna see here. So now let's take a look. He also has a tear in his ERCV, and we're gonna see that pop up here. Follow this up. You're coming over the radial head, and then we've got a partial tear right in this ECRB as well. So we've got our EDC, ECRB, EDC, and then also this goes down into the radiocollar ligament. So we do a little bit of pathology here to treat. So typically, I'm gonna obviously know this patient before I see them in the procedure area. I'm gonna mark out my borders of where I want to treat. And typically you're going to want to toe in a little bit anteriorly, and hopefully you can see my hands there. Can you guys see that? Yeah, okay. I'm going to mark with a surgical pin here. Could be a towel from up there. Sorry, I'm grabbing a towel so I can actually mark this thing. There we go, that'll work. All right, so I'm going to wipe this off just a little bit. So I'm going to slide my tendon. So it's at the very far edge of the transducer. I'm going to mark it, and I'm going to slide it back here. And assuming if I felt like that ECRL was part of the pathology, I could remove that little nugget there. It probably isn't. This is probably something that he has had, but I'll probably concentrate more on this partial tear here. And we're going to see that this will open up when we inject it. And so typically I'd start with numbing. So this is, I mark my borders. I'm going to try to come down the center of this and make sure that we're treating the right area. So anyway. So obviously I would numb this first. This is obviously a cadaver, so this may or may not show the way you want to do it. So I would come in with my needle first, hydrodissect everything superficial off of here. So yeah, it's a little sticky. Ice. So it's still a little freezy. So I got a little sticky because of the ice. And so then I come to intertendinous, right? Let's find that tear. There it is. Okay. So it's in kind of a typical area. You can see, this is what I mean by I think all these have tears in them. This guy may or may not have been symptomatic, who knows, but this looks like it might be around 20% or less of the tendon, but it goes down into that radiocollar ligament. So I'm actually in the ligament here, right up at the top part of it. And so this guy has a partial tear. So I would numb this up, leave myself a nice skin wheel on the way out. And this is a 15 blade. Normally it comes with I blame the rep. Anyway, normally it comes with a 11 blade. And now let me switch my hands so you guys can see it a little bit better. Normally I would use my right hand to do procedure, but we can do it here. And so I typically, for billing purposes, always take a picture of a blade coming into the tendon. And this is not cutting as well because it's a 15. So we'll get that nice view of the blade kind of going into the tendon. Take a picture there. That way you say, okay, I did a tenotomy. I cut into the tendon. Okay. If you can do it, some of the hamstrings obviously can't do that. And then we'll guide the device down the hole here. On cadavers, it's always a little bit, man, this is really you'll see blood, obviously, but let me switch my hands. Normally I hold this with my right hand, but I'll do it this way. Notice I come over from the top on this device here. So I'm going to come my hand from the top because it's a very superficial tendon. If you angle too far steeply like this, you're gonna bury this into the bone. And so I'm going to try to find my hole here. There we go. Good. I'm gonna find the device on the ultrasound here, and usually I'll try to insert this in short axis and get it from my hole. Bear with me. Just get a little freezy. Normally in humans, it doesn't take that. Well, not that this isn't human, but it doesn't take that much force. So I'm going to come right down the center of it. I'm going to turn around a little bit just to get into the tendon. Noise. I'm going to work through this like a grid, right? So now I'm down into the tendon here. And you can feel it go into the tendon through it. So I'm going to kind of clean out that area. You may hear a beep, but the machine's telling me that it's flawed. So you hear a beep here. So once you hear the beep, you got to let up on the pedal, okay? Let it clear. And then the other option is to turn the cutting off. You leave the aspiration on. But I think if you're kind of constantly on and off the pedal, we're working your way through this area, a little bit of movement on the needle tip to help. And then I'm going to turn like a grid here.
and kind of see where I'm at. So I can follow the needle down from the skin, slide a little bit distally, and then maybe head a little bit posterior here. All right, center here. There we go. Let me check my depth. So this is a constant back and forth that I'll do. So I'm putting this out. So work through it like a grid. Like I said, about a minute and 152.2 seconds was our average energy time on this. You know, I generally keep the setting on this on the high aspiration with the medium setting for the cutting. If I'm going after bone, I'll turn on a high setting. This is with the TX2. TXB, be careful about the TXB heating up a lot. So you can see I'm keeping my my finger down on the actual on the actual device, so I can feel how warm it is, right? So this is just a control thing, 1, and 2, I can feel how hot it is. And if you just let it on and off the pedal like I'm doing, it usually won't overheat. If you just sit in there and like keep this pedal going, you know, and chewing this thing up like this, it's going to start heating up on you. Okay, especially if it's on the high setting, then you can get some thermal burns at the skin. You may have some wound healing issues, especially if you're going after a big calcification. Take the time, let up on the pedal, let the device cool. You know, otherwise you can end up with a thermal burn. So just a few tips there. All right, so we'll switch over to the medial elbow and then see if we can answer some questions here. I know it's hard to get your hands on when you're looking at hunks of meat on the screen, but all right, I'm gonna move this. I'm gonna try to get this right back in the same spot. How's that work? Sorry, the camera has a little delay on it. There we go. Okay, so looking at the medial elbow here, again, we'll go over a little bit of the anatomy. A little gel on here. A few things. Ulnar nerve is sitting off the back, and so it's very close to the retrocondylar groove. A little bit of ice there. Here's our 2 heads of our FCU tendon. Again, the most lateral head most lateral muscle you're gonna see is the FCU. Here's my FDS and FDP coming together, and then here's my FCR coming off the top, and then you're gonna see the pronator. This is a female elbow. This pronator is gonna come in and actually almost blend in with the FCR tendon. So again, it's much smaller footprint, much smaller tendon from the muscle belly goes right up to the end in this tendon, almost always, very few exceptions. And so, and I'll show you this long axis now. We're going to turn on it. And so I've got proximal to the right of the screen now. Here's my anterior band of my ulnar collateral ligament. Again, I tried to place this around 70 degrees to give you guys the best angle. So that anterior band of the UCL heading down to the sublime tubercles here. So now, in this case, I'm going to slide proximal, but also rotate clockwise to get those tendons in view. Now, the first tendon I'm going to come into contact with, again, we just talked about this, is my FCU tendon, my ulnar head of my FCU, which actually inserts right here. Doesn't quite go up into the tendinous complex, maybe a little slip heading up here. Now, I'm going to keep going, and we're going to see the flexor portion of the FDS and FDP coming together. And then my next tendon, which kind of is really, they all kind of blend in this particular model. Here is my pronator teres on top of my FCR, right? So again, I'm going to turn sideways and see that happen right there, okay? And so I would do this in the lateral recumbent position, coming from distal to proximal. I'm going to switch hands again because I'm not as good with a needle with my left hand, but we'll make it work so everyone can kind of see what's up. I'm going to shoot a bunch of water on the floor. You know, my needle came off the syringe. Make sure your needle's securely on the syringe. It's more good advice. And so I'm going to numb this up first. Now notice, check this out. So this is this little guy right here is the nerve. Let's see that go back this way. See that? Okay, so this is coming off the ulnar nerve. So this is your epicondylar branch off the ulnar nerve. So it's sitting right here. So don't pulverize that thing with your device. Okay, just know where it's at. Okay. Anyway, so another good example of what to watch out for when you're doing this. So just stay in low. And so we're going to numb this thing up. Again, it's very superficial. So I'm going to peel all this off and numb the heck out of that nerve there. Now I know where it's at, right? We're going to peel it off, use a ton of volume, and numb the heck out of that thing. So I use, a lot of people use blocks in this. I don't think it's necessary. I've never really used them. I did for a while, but I guess if you're asking for somebody to have a reaction to your block, and one lady that had a reaction to the ropivacaine around her nerve, and that was worse than darn surgery. So anyway, I just local anesthesia, and I'm gonna come into the tendon here, see if it's binding here. So sometimes they have tears, give them a little bit more proximally, kind of right down in this area. There's all this normal tissue anyway. So come on, guys, you can't get me one with pathology. I'm just kidding. All right, and then I come in, numb the tendon. Once you feel like the tendon's getting numb, you go work through it like a grid and kind of off the back there. Yeah. So again, you can come into the tendon, make sure you've numbed all the way in here. I'm just kind of, this is kind of how I move it in a grid with the Tenex device as well. Make sure you get much of the time like there's a tear in the center. Maybe I can create one. Yeah, there you go. Okay. Sort of creating a tear in there. I don't think there was one to begin with, but so this is kind of up in the FCR pronator portion of this tendon here. And so once that's good and numb, we'll use the same kind of approach here for where's my mesh? There we go. Okay. Coming just a little proximal here. And I come a little bit closer to the tendon on this one, coming in the short axis. So that blade come in there. Always get a picture of the blade and the tendon, picture there, and then come back in with our device. I can put in the hole of that. This is always the hard part with cadavers, we don't bleed. So there it is. Okay. I like doing, I think the more comfortable you get with ultrasound, you initially start wanting to do everything in long axis. I like to do a lot of things in short axis, including carpal tunnel, things like that, because I think it's just a little bit easier to see what you're doing. So I get it started in the tendon. That's kind of the angle I want to go. And I'm going to flip the screen so it stays the same. Let me flip my hands out of the way. You can see again, I'm coming from on top of the device here because it's a very shallow tendon with this particular tendon. If you try to put your hand underneath it, you're going to come at too steep of an angle. Just things you learn over time. So obviously I want to get way down to the tendon. Again, it's a very small tendon. You can see I'm controlling my depth on this with my hands, and I'm pushing the ulnar nerve down with my transducer hand. So I'm kind of pushing the ulnar nerve out of the way. So I know where it's at all times. And again, not real exciting to watch this film now, but I'll work through it like a grid. I'd come back out. I'm like, okay, I want to come to that pronator portion of it. And then move it a little bit anterior. There we go. Come down to that portion of it. So I want to like a grid, hit the portions where the abnormal pathology is at. If it doesn't look abnormal, I don't touch it. So that's the other part. Just try to stay where the pathology is at, right? If you're like, don't do more than you have to get somebody better. But again, that's kind of my approach to the elbow. Obviously, medial epicondylitis not as common as lateral. I do maybe under 20 of these a year, and I'll probably do close to 50 lateral elbows at least a year. One of the more common tendons affected that Tenex seems to be very effective on. All right, hopefully you guys can hear that enough. I'm sorry if I was talking too quietly without being away from you, but I'll just kind of walk over to the computer here and see if anyone's got any questions or